Top Med Talk.
Linkage Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
I now have the pleasure to introduce Associate Professor Vasi Naganathan, who is an academic at the University of Sydney and a consultant geriatrician at Concord Hospital in Sydney. He's actually got wide-ranging research interests with a particular focus on collaboration. So he's our next speaker. Thank you.
So can I put some context to my talk? For the 18 years I've been at our hospital, our advanced trainees have been saying to us, you know, the vascular patients, they really need our help. We should do what we do with orthogeriatrics. We should provide them with a blanket service. When we've discussed this with the vascular surgeons, they say, yeah, you should come and help us because we're frustrated by the fact that many of our patients end up with many physicians who give conflicting advice. We appreciate the fact that you give holistic care. We should think about who you're actually going to see. And we've heard rumours that the vascular surgeons elsewhere are getting a better service from their geriatricians. Now, I have to say the vascular surgeons we work with are an enlightened bunch. They're all younger than me. Sarah Aiken, one of the surgeons, asked to do pre-internship with us and internship with us because she said, I'm going to be a surgeon, but I sure as hell need to know my geriatric medicine if I'm going to be a good surgeon. And the anaesthetists, well, they've kept it simple and simply said, look, they really could do with your help. Now, the question is, should we just do this? Now, there is the no-brainer argument, which is that if you walk up to the ward, it doesn't really look that much different from our ward, right? They are frail and older people. And we've heard a lot at this conference about risk factor tools and frailty and how it predicts bad outcomes. And if orthogeriatrics works, well, why wouldn't vascular geriatrics work? And there's evidence. We've heard about the work at Sen Thomas's. And already the guidelines are saying if people are frail or if they're at high risk, the guidelines clearly say that are coming out that they should see a geriatrician. But if you're like me, you might say, and a bit more cynical, show me the money. You know, what's wrong with the current consultation service? How much physician-y, geriatric-type problems do they really have? Are they really the same as the orthogeriatric patients? What's the evidence? What's the direct evidence? You know, David Story showed impressive evidence for things, right? Are we anywhere near that? Which subgroup will it work in? What should the service look like? You know, one of my collaborations has been with in the area of oncogeriatrics, and there was a real push that, you know, older frail people need to see a geriatrician and an oncologist. But when they did the studies, we're yet to have this landmark study to show that's a good thing. And we've done some work locally to also question that, because they're a different group of patients. And the other final reason is we're supervising a vascular surgeon, Sarah, and a geriatrician, and we've got to give them something to do. So this is the outline of my talk. I'm going to explore that question about who are these patients, both at a big picture level and then show you one particular study. Then look at a bit about what's happening in Australia and New Zealand on this concept of co-managed care of non-orthogeriatric patients. Look a bit at the evidence. And because we haven't, I'm going to then get Christina from Prince of Wales at the end of my talk to talk about their model of care, which is one of the better developed models of care in Australia. So some big picture stuff. So Sarah has got hold of New South Wales data, linkage data, and focused on patients who've had a vascular procedure between 2010 and 2012, and also got data going forwards to look at outcomes, and going backwards to get better data about their comorbidity. So keep in mind this is data, linkage data, with all the limitations of coding data. So more than 38,000 patients in that 3-year period had a vascular procedure. There were more than 38,000 patients in that database, and in that database there were 60,000 major vascular procedures. And this gives you an idea of their procedures. So a few things there. You can see the rates of endovascular. You can also see the number of people having minor surgery for wound debridement and minor amputations comes in that group. And the number of people having second procedures, 2 or more procedures, which I certainly didn't appreciate. Here's an idea of their comorbidity, and this is what you'd expect in this group of people. And here's some mortality data. So at this conference, people have talked about acute lapse, and the 10% mortality seems to be the figure people are talking about, at least in the immediate period. In orthogeriatrics, people talk about 20 to 25% one-year mortality. So in a way, this group are falling below that. But then look what happens to the 3-year mortality. Look at, say, the top green button there, dot there, endovascular. Look how that 3-year mortality, how it exponentially rises, which probably has something to do with the nature of these patients. As you would expect, the predictors of mortality in our data were older people, those who'd suffered a complication, in this case 30-day complication, cardiac complications, and if they came back and forth to hospital. This gives you an idea of the perioperative complications in the first 30 days. When I look at this data, which looks at taking out some key complications, and I think anaesthetists would appreciate this and surgeons, I was struck by, in the aortic surgery group and the lower limb arterial group, the number of people who within 30 days had surgically related complications, which you don't see in the orthogeriatric group. Length of stay. So the carotid group, as one of the vascular surgeons told me yesterday, just come in and out of hospital quickly, whereas those with AAAs and lower limb arterial surgery stay for longer. So there's work for geriatricians there in helping look after their inpatient stay, clearly in those two groups. Older age is associated with the things you would expect. Look at the readmission rate. So this is the other thing we were struck by. 6% in 30 days, and a quarter in this whole group come back at 90 days. And in the older people, a third come back to hospital, not necessarily under vascular surgery, but come back to hospital. Again, they're different from the orthogeriatric group. So we thought we'd look at one particular group, and I'll show you the data from, these are people with lower limb peripheral vascular disease who are having a open or endovascular procedure. So they're obviously an older group. More people are having endovascular repair, endovascular procedures. A third have critical limb ischemia. And so you might think about that when people are talking about prehabilitation, whether they're up for it, and what the previous speaker spoke about, they're somewhere between truly elective and coming through the emergency department, as you know, many of these people. They're their comorbidities, which you'd expect. And the perioperative complications, again, we were struck by the surgical-related complications, and because this is relying on coding data, you can assume the rates of pneumonia and delirium are a big underestimate. Look at this group. Look at their readmission rate. Right? More than a half come into hospital over 90 days. So if we're going to set up a service and provide some continuity of care, are we going to have the one geriatrician who will see them and keep in contact with them and look after them wherever they're admitted in the hospital? And it also tells you something about vascular surgeons, right? They are their main specialists looking after their patients. And if we're going to be sticking our noses in their business, We need to be respectful of the fact that they have a strong ongoing relationship with these patients, which certainly anecdotally we appreciate, but it's interesting to see that in numbers. And look at the rates of reoperation, right? The group having reoperations, which again has implications for the kind of service we provide. I'm not sure I'd be interested in the anaesthetist view whether this has implications. But there'll be a lot of people who are having reassessments about their risk for surgery and appropriateness for surgery between the various groups involved with their care. And end-of-life discussions and appropriateness of treatment is going to come up a lot in this particular subgroup of people. And Sarah thought it'd be interesting in this era of lots of data coming out in the AAA literature to look at what are the outcomes people have looked at in people over 80. And I said to Sarah, are you sure there's much data on that? And she said, well, she did the systematic review and she found 40 studies, 2 of which had large registries, so there was certainly more data than I appreciated in this. And she looked at the various outcomes, but they were dominated by procedural outcomes, surgical-related complication outcomes. And given that we've talked about these people coming back and forth to hospital and having lots of procedures, there was nothing explicitly in these 37 studies looking at people over 80 on physical function, disability, and cognition. And at the same time, around the time we published this study, there was a small but neat qualitative study that took people of all ages after they'd had both endovascular repair or open repair and did some focus groups and asked them what they thought was important in the context of their aneurysm surgery. And they said, surprise, surprise, physical function, recovery time, length of stay in hospital, impact on caregivers, and right at the bottom they had dying and serious complications, which is sort of the reverse of what I showed you in the previous slide. But, I've shown you gross data, and I thought I should at least show you one study of some, more data with some more granularity. And so this is from Sen Thomas's work. So really I'm looking at the question, are they my kind of people, really? Well, this is looking at 65 people who, on the basis of the Edmonton Frailty Scale, were considered frail. So you can see, they've got the things we love, polypharmacy, some heart disease. I was impressed by the CKD there, 30% CKD greater than 3A. They've got the geriatric syndromes, right? 40% had a fall in the previous 6 months, preoperative anemia. And this gives you an idea of their post-operative complications. It's interesting that, again, that rate of delirium seems to always be at that 20 to 25% in the studies that we look at. I was surprised. I thought the rates of heart failure were lower than I'd expected. Look at the rates of falls on the ward, that's 15%. So 50% had composite complications, which pretty much matches the data that Jackie Close showed you earlier. And then looking at functional outcomes. Again, the kind of things you'd expect. So, hey, they really are our kind of people, right? They've got comorbidity, frailty, geriatric syndromes, so our advanced trainees were right. But they are different in many ways in certain things from the orthogeriatric group and the acute lung colleague group that we've been talking about. As I said, they have lots of surgery, ongoing surgical involvement, lots of coming back and forth to hospital, certainly in that proportion, say, with lower limb peripheral artery disease. So in light of that, maybe our surgeons are right. The rumours they've heard, maybe there's a whole bunch of geriatricians doing a lot of co-management with vascular surgeons. So we sent Janani, one of our young consultants who's also doing a PhD with us, on a bit of fact-finding mission, or spying if you like. So she conducted an online survey to find out about what are geriatricians doing in terms of co-management with non-orthopedics. Right? So we really had no idea about this. And it was an online survey. And we had a great response from geriatricians in Australia and New Zealand. So we think there are about roughly 80 departments in Australia and New Zealand, and we got a response from 83% of them. And we found that the majority of departments were providing only a traditional consultation service, and only 12 units were, at least for one or more departments, were providing a more co-management model for non-orthopedics. And in terms of vascular surgery, only 4 were providing a co-management model. So 8 were providing it for colorectal. So you can just get an idea there of the spectrum there. And that's interesting because I looked at, this is some US data where they've got hospitalists, and this is sort of old data using, if you like, based on funding. And you can see that the red line there is that, 30% of vascular departments, or where vascular surgery is being conducted, they have a hospitalist providing co-managed care. And when we ask people in this survey, who do you think needs our help the most? Just like our advanced trainees, they said vascular surgery. So 50% said vascular surgery of the various surgical specialties need our help the most. And these are some of the other things they said. So it's interesting. They said there's good evidence for vascular surgery, so hold that thought. And then you can read there some of the barriers they talked about in terms of providing co-management care. So they said, someone said there's good evidence for vascular co-management care. We've heard at this conference, both from the published Cochrane Review and Allison's work that's yet to be published, that actually the evidence isn't that strong for co-managed care for in the non-orthopedic setting. We've heard a lot about the Sen Thomas's study, and the thing to keep in mind was that it was elective vascular surgery, not emergency surgery, but you could ask, is it a no-brainer? It should work in that group as well. The number needed to treat, I think, are pretty impressive. Here's another study that actually doesn't get so much publicity. This is a before and after study done in the States with large numbers that took people with ASA 3 and above and who were going to stay in hospital for more than one day, that showed benefits in mortality and complication rate, but no difference in readmission rate. And again, that high readmission rate. And Allison hasn't published this, but this is a neat study done on the vascular ward at the Royal Brisbane, both elective and emergency patients, both having medical input from a general medical unit, but also, I get the impression, good involvement from allied healthcare, right, with the Eat, Walk and Engage program. And that gives you an idea of what was in the black box. And the things I'd like to highlight is there the weekly team meetings and the daily huddles, discussions about quality improvement, and good numbers, actually, I think, 100 on each arm. And, sorry, we'll go back. You can see that there were differences in delirium and functional outcome that didn't reach statistical significance of the group as a whole, but when you took the group who were admitted for urgent reasons, significant difference in delirium and functional outcome. And I like this slide, a difference in length of stay and a difference in the outcome of who was discharged home. So, going back to our question, there are certain groups that are clearly our bread and butter. There are some unique aspects to them, which I've talked about, so we need to think about that. Vascular geriatrics is clearly starting in some places, and I think it's important that they collect data either in the before or after trial design or quality improvement. We've talked about this, but I think because we've did some work which we didn't collect any data on in the vascular group years ago on staff education. I think there's a question about how many of this group will be up for prehabilitation, if I use the critical limb ischemia as an example. Pre-admission clinic, do we need to run a semi-urgent pre-admission clinic for those people with critical limb ischemia? And I really want to know what the anaesthetists think about all of this, which is obviously very, very important, and we need to explore that at our hospital. Now, I think you need to hear from someone who's actually running a well-developed service. So I'm going to get Christina just at the end of my talk to talk about the Prince of Wales service with vascular surgery in mind.
Thank you, Vasi. So just to sort of give you a bit of an example of what we're doing at Prince of Wales, as Jackie mentioned earlier, we've done a number of shared care models for a while now, first starting with orthogeriatrics. Vascular surgery was actually the next cab off the rank for us because there was a very clear need, we felt, and the vascular surgeons felt, for our care there. General surgery, the COPS model, and plastic surgery now is the next step that we've gone into. Just to give you a bit of an idea of what that model of care looks like on a day-to-day basis. So we really focus on a number of things, looking at cognition, screening for cognition in the first instance, not just for cognitive impairment but for delirium as well, and coming up with a plan in advance to prevent delirium but also proactively manage it in case it does occur. And a lot of that is working with the nursing staff who are on the wards, who really are, I think, the champions here in delivering that care. We look for geriatric syndromes. A lot of these patients, particularly in plastic surgery but also in vascular surgery, have a recent history of falls. And so in some ways they are very similar to that orthogeriatric population. Frailty, incontinence, preventing pressure injuries from developing, and really looking at optimising bladder and bowel care, getting lines out earlier, getting patients up moving, and really making sure that they don't develop those post-operative complications. Multimorbidity. We know that a substantial proportion of the patients that we see are multimorbid. And this doesn't just have implications in terms of optimising them, whether they have a procedure or not, but really meaning that we need to be very proactive in terms of having some plan to preempt that complication. A quarter of these patients have atrial fibrillation who are coming in under vascular surgery, and so being able to anticipate what will happen if they develop it, how can we prevent it in the first instance, what things can we do to make sure that that happens appropriately. Some of that may be that we are consulting other specialties, but when you've got lots of other specialties involved, it can be really hard sometimes to get a clear, comprehensive plan that has everything in mind for that patient. So being able to coordinate that is really important. So we sort of say to the vascular surgeons, we'll look after the medical consultation side of things. If we think, if this is something we need to consult about, we will go and ask. Medication management, really important in this cohort. Huge rates of polypharmacy. Patient education. Now, that's something that's been mentioned a few times, and I actually think a lot of what I do every day is talking to patients, just simply explaining what is going on, why I'm sort of saying it's really important to get you up and moving, why their nutrition is important, why those deep breathing exercises are so important in terms of preventing complications. Nutrition and fluid balance, particularly important. I think, for the surgeons, you're in theatre a lot of the day. And so being able to have that time to do sort of quite a comprehensive and involved clinical assessment of someone's fluid balance is not something that's high on the agenda. So that's something very definitely that I do as part of my care. Screening for malnutrition. And in particular, in those patients who are cognitively impaired and delirious, promoting oral intake that is going to work for them. Patients are fasting for a long time. Often if the diet order's been put in that they can have their diet upgraded, there might be hours to wait. So one of the things we've done is we've got a fridge available on the ward so that if and when we know that person has been allowed to start eating, we can easily go and grab some cheese and crackers, something, finger food, in particular for patients who are cognitively impaired, that they can sit there and grab a hold of and get that extra intake in. Early line removal I've mentioned before, as part of bladder and bowel care. Mobility and function. So a lot of these patients were not seeing physiotherapy. So one of the things that we do is very early on, not just waiting until, say, after surgical intervention to get physiotherapy involved, getting physiotherapy in early, talking to the patient about how we can prevent functional decline and keeping them moving from the get-go. And that early discharge planning, we talk about early discharge planning starting at day 1. And in terms of who does this and how it works, we offer a daily registrar review at an advanced trainee, Monday to Friday, and a geriatrician review twice a week. As part of that, we have our joint round once a week, which is the vascular surgery grand rounds, and that gives us also an opportunity to talk about other ways in which, particularly from a discharge planning point of view, vascular surgeons might consider how this patient may be able to transition back into the community. The key things that bring this all together, I cannot underline this enough: communication and care coordination. Communication not just with patients and farriers and their carers, but more broadly within the multidisciplinary team, and that includes the GP. Unless there is that smooth transition, that's where we're going to run into trouble in terms of readmissions. Particularly in this patient cohort, it is about also recognising what the expectations of the patient are, and really being able to, within that, sort of talk through, well, what's likely to happen here? Goals, what's important to you? Most of my patients will say they fear being in a nursing home far more than they do death. So for these patients whose outcomes, as Vasi's documented, really are very limited, it's really important that we set goals of care and deliver that care within what their wishes are. And outpatient follow-up. For a lot of these patients, they're coming in from aged care facilities, so being able to follow them up within the nursing home, particularly if they're less mobile and able to come in and be seen at an outpatient clinic, is particularly important. So we offer a nursing home liaison service, and we'll often proactively follow these patients up within their own environment. If we do demonstrate that they've got some cognitive impairment, making sure that they get seen at memory clinic, and likewise falls and fracture and fracture prevention as well. Care coordination. The other thing that became really apparent when we were doing the observational study was that care really did seem to be happening in series. First, you'd be dealing with the surgical problem, then there would be this focus on, great, the surgical problem's dealt with, how are we going to get them home? So things did seem to be not really happening in parallel. So being able to sort of pull that discharge planning really from day one to sort of say, well, we know you're going to be in hospital for a little while. Where are you going to go afterwards? And if you can't get up and walk by yourself, or you can't shower yourself, or you can't toilet yourself, what are we going to do then? And as Allison does as well, we also conduct daily board rounding just in terms of that coordination process, and twice weekly case conferencing. So that's really sort of what it looks like on a day-to-day basis. But I think the most important thing here is, although there are some clear themes across each of the surgical specialties, it really does require a tailored approach to each individual surgical specialty. Thank you very much.
Geriatrician here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.